Okay, Ahmed, let's go and start. Getting late.
Okay. A patient presents with syncope and acute left lower quadrant abdominal pain. في هنا hidden word. He is
Can you read it?
I cannot read what is behind the box. The search
Oh,
box.
the box, no? What is that?
He is
Sorry.
resuscitated in the emergency department and non-contrast CT scan is performed. He is hemodynamic.
No, like difficulty breathing or swallowing, anything like that. She has very mild arm swelling.
Okay, go ahead, Ahmed.
Okay, sorry. A patient presents with syncope and acute lower quadrant abdominal pain. He is resuscitated in the emergency department and non-contrast CT scan is performed. Figure. Okay. He is hemodynamically stable and is taken to the hybrid room for endovascular repair. If coil embolization is attempted, occlusion of the posterior division of the internal iliac artery is necessary to reduce the risk of back bleeding from the...
What does he have? What do you see in the picture?
I see an internal iliac artery aneurysm, pseudo-aneurysm or aneurysm.
Yeah.
A huge one.
Yeah, the huge aneurysm. He came with a syncope. Doesn't look like a rupture, even though his symptom giving
Contained. The wall is
sign
intact.
of rupture.
Mm.
I don't know, yeah, but I don't see
But this is
hematoma.
non-contrast.
So the huge aneurysm with the pain and syncope.
Mm.
So how do you treat this one? I mean, the picture is not very clear, but how do you do it? How do you treat like large aneurysm like that?
Either you land from the common iliac to the external iliac with covered stent and embolize this aneurysm or the source of aneurysm in angiography first. This was non-contrast CT.
You cannot only just cover it. I mean, some people see just cover the entrance. It's not enough because you get backflow from the posterior anterior branch of the internal iliac artery. So you need to embolize it. So first you need to go inside, look for the anterior and posterior branch, and then embolize them, and then you put a cover stent, you know?
Yeah.
But if you just put a cover stent without embolization, it's become a disaster because you can't get access there, you know? It's become very difficult. So this is very, very important, you know? The problem with putting a cover stent is discrepancy between the common and external iliac artery. Because common iliac artery is large and external iliac artery is smaller, you know.
We can VB exit and balloon the proximal more. It will shorten, but you will overcome the discrepancy.
Right, but in general, something like that, it's better to use a self-expandable cover stent, not balloon expandable, because self-expandable takes the shape of the artery. So in this scenario, most of them use like an iliac limb, because iliac limb, they come like 16 by 13, 16 by 10, you know, so they are tapered. So you can put like 16 in the common iliac artery and put 10, depending how big is the external. So it's better in this case to put a self-expandable cover stent, like one of the limb from the EVAR. Better than put a cover stent. Yeah, I think so. Especially if you have a major discrepancy between both. If it's not major discrepancy, then yes, you can use balloon expandable stent. Okay, so what do you want? What's the question now? They said
the posterior division.
The most very important if you use an IBD, a bifurcated iliac device, is to look at the iliac bifurcation and be sure you keep a flow to the posterior division and anterior division. You cannot sacrifice any of them.
If you don't mind, that's good. Thank you.
Muhammad Mana. Because if you sacrifice one of them, the posterior or anterior, you can get, you know, claudication or impotence, right? So here's a question. The posterior branch is of the iliac artery. Give to which artery?
It gives the lateral sacral and superior gluteal artery.
Yeah, that's correct. The superior gluteal artery. That's the reason why you get a gluteal claudications, you know, if you close it. And the anterior branch, you know, the anterior branch.
The anterior branches has many, vesicle, and I think obturator, the female's uterine artery, among others.
More genitalis and pelvic. Or the procedure mainly go the close. That is why important to keep both, you know. Of course, I mean, if patient's young, I think the best way is to open repair, you know. You open repair and you fix it here, and then you go endo ligation. I mean, open the sac and ligate the artery from inside. I think if it's young patients, old patient, then it's EVAR. I mean, the stent stuff work fine. So nothing in this question, just straightforward, really. So let's go, not waste too much time here. Let's go to the next question. Here. Abdullah, you want to take this question, Abdullah?
I'm driving, doctor. I will
No, don't do it. Let's see, Maysam. You want to take Maysam?
Yes, Dr. Samer.
Okay.
So this is a patient present to clinic 1 month following successful endovascular repair of left internal iliac artery aneurysm by embolization and diverting inflow with covered stent across the origin. So he has a palpable distal pulses and no abdominal pain. The imaging studies demonstrate thrombosis of the residual aneurysmal sac. He noticed that he has been suffering from mild cramping in his left buttock after he walks about 1 block. You advise him that buttock claudication happens in about 20% of patients after this procedure, and the time of interval post-operative in which typically resolves is, well, it takes like about 6 months to resolve.
This is the average usually, yeah. I mean, a lot of it is like a science behind that, but most of them, they dissolve within 6 months because they form good collaterals with an active exercise. So again, I mean, but you see that even single embolization of the internal iliac can cause complications. So these days, really, most people, they try to preserve both internal iliac. Even one single iliac embolization can cause even impotence, you know. So nowadays, I think the trend is to keep both if you can. If you cannot, you can sacrifice one of them. But if you can, I think it's better to keep them both. Muhammad, what do you think? Do you like to keep them both, or you always sacrifice one of them? Dr. Rafat?
If they're young and I can save it, I can keep both. I'll keep both. Not, it's reasonable to embolize one and then you keep the other one. And there are two thoughts about how you do that. You do that either with at the same time with your EVAR or procedure. You can embolize it and do your EVAR. And some people like to do them a week before, so they see, they worry about ischemia and things like that, bowel ischemia, so, and then they come back and do it again. And the option is sometimes in old people, in active people, and you need to get rid of both. You get rid of both, but you wait time in between to develop collaterals. So
yeah, I mean, if you have to sacrifice both, yeah.
In the old people only. Only time I've done that in very old people. They are not active, they're not running, they're not sexually active, they're not, they're just old people in their late 80s,
So 50 years old with aortic and both iliac aneurysm. Do you do bilateral IBD or sacrifice one and put IBD in one side?
I do bilateral IBD in this patient. If it looks good, or I do it open. If it's 50-year-old, probably open.
Yeah. So again, I think the trend now is that before we saw just, embolizing one is enough and very safe, but these days, no, we don't believe that. Even one is not enough. And you saw like 20% of claudication. I think impotence maybe about like 7-8%, even with a single embolization. So if you can keep them both, I think it's much better. Yes.
Yeah, the
IVE is the trend these days. Yeah.
Bilateral IVE can be technically challenging, but now Gore has a flex sheet. It's called. It's very flexible. So because you have to go up and over and bring the device on the other side. So but it's doable. You can do it. At the same time, you can do it. It not be difficult, but it become difficult later on. But you use the flex sheet. What is human?
All right. So again, let's go not much about this question. Let's go to next questions. Sam, I want to take this one, Sam. Yeah, go ahead, Ahmed.
No. I have residents here with me. I tell her just they're doing visa here.
Okay. Muhammad?
Yes.
Sorry, Sama, sorry.
Yeah,
Sama?
yes, Dr. Samer, yes. 62-year-old man is undergoing an open repair of abdominal aortic aneurysm with concurrent aneurysmal degeneration of the right common iliac artery. After completing the proximal aortic anastomosis, the right common iliac artery aneurysm is opened, and the short segment high-grade stenosis of the right internal iliac artery is observed 1 centimeter beyond its origin. The left internal iliac artery is occluded at its origin. The decreased risk of pelvic ischemia, the best distal reconstruction technique would be?
So you have a patient with, you're going to do aorto by iliac, EVAR, aneurysm repair open. And then you notice that one iliac is occluded, the second one has a stenosis, but the problem is 1 centimeter away from the origin, not like at the origin. So
Yes.
how you deal with that? And you only have one internal iliac. Well, let's start one by one.
Okay, we'll start distal anastomosis at the right iliac artery bifurcation.
Is this enough?
No, I don't think it's enough. No.
No, it's not enough because the stenosis is 1 centimeter from the origin. So even if you do that, you still have a stenosis on one iliac and the other one is occluded.
Yes.
So he may end with a major,
Pelvic ischemia.
pelvic ischemia.
Yes. B, distal anastomosis at the right external iliac artery with ligation at the origin of the right internal iliac artery. So you're doing bypass between the right external and the right internal. Could be one of the options.
This is correct or no? Do you do this correct to do this way? B?
Distal anastomosis of the right external iliac artery. I'm not sure.
The origin is right internal iliac artery. So you didn't solve it because the left is occluded. Now you close the right, so it didn't help him, right? We want to get the blood to the internal. The whole idea from this question, you want to get the blood to the internal, right?
Yes.
Okay, so the first question, you just did anastomosis, but you didn't get blood to the internal, so it's wrong. Next one, you did anastomosis to the external, but still you ligate the internal, so you didn't get flow to the internal. Still, we didn't solve the issue. The patient issue here is you need to get blood to the internal, correct?
Yes.
He only has one. If the other one is open, I may not worry about it.
Yes, we can.
Because the other one is occluded, then you have to get the blood to the internal.
Okay. C, ligation of the common iliac artery and distal anastomosis at the right common femoral artery. Also, this is not right because we still didn't solve the issues. Okay, D, distal anastomosis at the right external iliac artery with an additional graft to healthy segment of the internal iliac artery. This one, I think, is doable. Let's see the last one. Endarterectomy of the right internal iliac artery with patch angioplasty and distal anastomosis of the graft at the right iliac bifurcation.
Okay.
For me, I think D the right answer.
Additional graft.
Additional graft. Yes, additional graft from the external. Yes, additional graft from external to the healthy part of the internal iliac artery, which is 1 centimeter away from origin.
What about E? Why is wrong E?
Right iliac bifurcation. We don't usually.
I mean, it's feasible, but it's difficult because this intent goes down, so you have to go and put a patch and then put. Yeah, I mean, it's feasible, but it's not the best option. They want the best option, But between me and you, I don't think I will not do any of them. You know why? Because as I said,
you
from this
don't
question,
like the anastomosis to the
right
external?
answer. Huh?
Because you don't like the anastomosis to the weak, bad external.
Yeah, because you did anastomosis external. I never do anastomosis external. External is the worst artery. I just said, guys, over external iliac artery, deal with external like an SFA. We never do bypass with the SFA.
Yes.
Or we go to the popliteal or common femoral artery. So external iliac artery really acts like an SFA. It's very bad artery for anastomosis. So if I cannot do anastomosis with the common iliac artery, I go right away to the common femoral artery. I will not do it. So in this situation, I will go to the common femoral artery, do aorto by fem. and then I'll do a jumbo graft or just cut and re-anastomosis the internal iliac with the external. Of course, and you ligate the external proximal. So this would be my best approach. But to put the graft in the external iliac artery, I don't think is a good options. So in the exam, it looks like D is the right answer, but I don't agree with that. Muhammad, what do you think?
Well, I think I agree with you 100%. You know, it's just better to go the common femoral artery. Now, you know, in life, like anything else, there are people who had redo groins, there are people who have bad protoplasm. So you have to kind of approach every situation. I have done maybe a few times, and I agree with you, they're probably not the best thing to do to avoid going in the groin, distal external iliac artery, just right before the inguinal ligament. And I followed this closely. I was burned once and I had to come back and stent it. So, but the aortic by fem, for sure, you go the big, you know, for that one. There are people doing endovascular, you know, and then they do the iliac. In my opinion, if the patient can tolerate that big operation, just do aortic by fem and just be careful with dissection. Hopefully, no complication. So.
Right. I mean, the other thing in this patient, if you look, it's not a good questions. Because if he has no symptoms before procedures, why he have a symptom after the procedures? So we just do aorto by iliac at bifurcation. You don't, because he didn't have any symptoms before from the stenosis and occlusion, right? So why he should have a symptom after the procedure? We're not doing any changes.
Maybe thumb, maybe anastomosis too tight. Who knows, you know? But if he had
no, but I'm saying this is the way they put the question. If patient is asymptomatic, came to me with internal stenosis that was occluded and asymptomatic, I just do aorto by iliac. Why I should follow up as an internal let's say he has a symptom before?
I think the question is because the question, I think they're questioning regarding the aneurysmal degeneration in the right common iliac. So I don't think they want to do aorto by iliac. That's why the
no. If you aneurysm, always we do that. No, if you aneurysm, you just go on to the bifurcation. Unless the bifurcation is very wide, then you don't do it. But most of the time, you can do it at the bifurcation. You cut the aneurysm, you do it at the bifurcation. Unless the internal external is very wide, different from each other's, then you have to go to the common femoral. For the external, Muhammad, the reason why I'm talking about the external is very bad because when I trained, there was no endovascular. So if the external got any problem, you have to reopen the abdomen. But these days, because the endovascular is very common, so even if you do the external get a stenosis, also you can go there, as you said, you can put a stent. So yeah, no, again, it's not as bad as we thought, but I don't like iliac artery as an outflow artery in general.
I definitely agree with you. Like I said, I was burned once on this, but I follow them very, very closely, you know. So I do them, and I don't do them lightly. I do them if I can't go to the groin, you know. They're too risky to go to the groin. So
yeah, that's true. All right, let's look at the question. Let's go to 14. Any volunteer?
So I'm gonna leave. Patients already prepped. We gotta go. So we'll see you guys.
Muhammad, thank you very much. Good luck, man. Take care. What do you have? What case you have?
Not too excited. Especially some fistulograms. It's not.
Okay. Take care, man. Take care. Bye-bye. Thanks. Who want Ahmad, you want to go back again?
Yeah, okay. A 32-year-old man arrives in shock following motorcycle collision. Radiographic evaluation reveals a splenic laceration and pelvic ring fracture. The CT angiogram shows blunt grade 3 aortic and semi-elective thoracic endovascular aortic repair, grade 3 aneurysm, is being planned. The utility of intraprocedural intravascular ultrasound, IVUS, is determined the proper endograft size for TVAR in a young trauma patient can be explained by trauma patient with a grade 3 aortic dissection. Grade 3 aortic
transection. Yeah.
Yeah.
So what we do for grade 3?
Grade 3 has to be TVAR'd.
Correct. Has to be. Well, even some people now question it.
Yeah.
But yes, I mean the guidelines TVAR, but I think Dr. what's name الله يرحمه
عصام هو الوحيد اللي كان
he presented some paper. Yeah, they treat him conservatively, you know.
Yeah.
But now let's go talking guideline. Guideline 3, yes, you need a TVAR.
Yeah.
We're going to talk about it. Why need to use an IVUS? with this kind of
Because
patient?
under resuscitated, under volume patient will have smaller
Correct.
diameters.
This is correct. So all these patients, when they come, they already have hematoma, pelvic fracture, they said pink laceration, pelvic ring fracture. So he wanted to tell you he's hypotensive when he did a CAT scan, okay? Because if he didn't mention this one, you can't presume the CAT scan is patient was not hypotensive, but he said pink laceration, pelvic ring fracture. So he wanted to tell you, and he was in shock. So he tell you that patient hypotensive. So when you do a CAT scan will undersize the size of the aorta. Because aorta change with the volume, right? So let's start one by one, Ahmed.
Initial CT angiography may oversize the aortic diameter in hyperdynamic physiology. The opposite is true. It undersizes.
Correct.
Aortic elasticity and compliance are directly related to age. This is correct, but not in relation to IVUS.
No, it's not correct. It's indirectly. Because
Yeah,
the more the older
indirectly.
become less
Yeah,
elasticity, right? Less complex.
Yes.
Will be indirectly. It's the opposite. Aortic
Yeah.
elastic compliance are indirectly related to age. The younger they have more compliance elastic. The older they have more. So the indirect. So this is wrong. Okay.
IVUS may account for the changes in aortic diameter during resuscitation. This is correct.
Yeah. So okay.
D. Angiography is better than IVUS for measuring the aortic diameter. It's the same because you inject a very small amount of contrast. So the volume is
really.
still low.
Not really. It's not that, because in the angiogram, it's very hard to measure. Because remember, I mean, the C arm and where the aorta, they are not at the same level. You see? So unless you put a catheter inside and you give it as to the machine as a guidance, then they can calculate the width. But in general, angiogram is not the best option to measure the width. You can measure the length is good, but the width is not good. Yeah, I think angiogram is not the best. Yeah. I mean, at least not better. It's not better for sure. Okay, last one.
Variation in aortic diameter during the cardiac cycle is minor in hypovolemic shock.
Is this true?
Not in.
Not minor.
I think
hypovolemic shock.
The
aortic diameter cardiac cycle is minor in hypovolemic shock.
The pulse pressure will be different. No, the variation should be high.
Yes, between systolic and diastolic, because in normal person we have a change in systolic and diastolic is about 10%, and especially in the anterior wall between systolic and diastolic. And this is the reason when we do a TVAR, we oversize 10-15%. People, they say, why oversize 10%? Not to hold it in place. The reason why we oversize at least 15%, because when you do a CAT scan, we don't know this is captured in systolic or diastolic. And most of the time you see like a hazing area around the aorta. You don't see like a circle exactly, because the CAT scan is captured between systolic and diastolic. So give you this like shadowing around the aorta. The reason why you need to measure from outer to outer, And we oversize because the change in the cardiac cycle between systolic and diastolic is significant. It's about, I think, if I remember correct, about 10%, even sometimes 15%. The reason why we oversize. And hypovolemic even worse, because you have a volume low. So systolic diastolic be major change in systolic and diastolic during cardiac cycle hypovolemic shock. So this is also wrong. All right. Any question before we go?
دكتور سامر بالنسبة للسؤال اللي من شوي الثاني, can we, instead of anastomosing to the external, anastomose to the internal and then jump a graft to the external?
Well, no, because clinic is difficult. Internals go very deep. I mean, really, if you see the internal could go deep in the pelvic and bifurcate early, so it become difficult. And you already have a stenosis there. I will not do that. No. I mean, you can do whatever you want. I mean, how do you want to get the blood? You see, any technique, I can't say it's wrong, but it's not the best. It's not the best. I mean, E is okay. And atherectomy, for me, it's okay. You can do atherectomy and put a patch. But for me, I mean, this question, If patient has no symptom before the procedure, I will not even, don't worry about it. Why I have to worry about it now? I just go aorto by iliac and bifurcation, I'm done. If patient has a claudication or like impotence and I want to increase flow to the internal, I think what I will do, either do aorto by fem and then cut the internal but in the external, or I'm able like aorto by iliac and then go through the graft and put like small stent in the internal iliac artery or stenosis, the vascular. You know, I mean, it depends how the surgery, how the technique, but all are correct, you know. But in the exam, you have to choose one of the answers they gave to you. But in real life, it's a lot of technique. But the whole idea is that if you have symptom, you need to keep blood flow to the at least one internal iliac artery. But jumbo graft is not a good idea. It's the best way, just cut it with the internal. It's easy. You can mobilize the internal and switch the external iliac artery. You don't have to put a jumbo graft because you can reach it there and the just have to go a bit lower and you can anastomose the external iliac artery. Any other question? All right, well, let's keep going. What question now? 32, we did this one, right? Yeah. Right. 15. Abdullah is still driving? All right, well, let's go to Samer.
Yes, Dr. Samer. 24-year-old helmeted motorcycle suffered a high impact collision. He arrived hemodynamically stable with normal neurologic examination. CT angiogram figures 1 and 2 shows an aortic injury, along with the left pneumothorax, lung contusion, spheric laceration, and multiple fractures. The most appropriate management for the blunt aortic injury is?
Okay. Before we go, let's talk about blunt thoracic injury. It's a very important subject, and I'm sure you can get a question in the exam, okay?
Yes.
You know what grade of aortic injury? How many grades we have?
Yes, we have 4
1,
grades.
2, 3, 4, right?
Yes.
Okay. What number 1?
Intimal tear.
Correct. Number 2.
Number 2, dissection or intramural hematoma.
Intramural hematoma.
Yes, 3 pseudoaneurysm, 4 free rupture.
Free rupture. Okay, so this is a 4, right? What the guideline tell us about grade 1 and 2? It's medical or surgical?
Grade 1 and 2 for conservative management and treating the other injuries as a polytrauma patient, but mostly conservative management.
So 1 and 2, it's medical.
Yes.
So it's just a tear or intra. Number 4, rupture, free rupture.
Yes.
You need to fix it, right?
Yes. Consider emergency. It should go to RS.
Number 3 is where controversy, you know?
Yes.
Because 3 is where the pseudoaneurysm.
Sure.
But the guidelines tell us what about number 3, what the treatment? Well, let's before take a treatment, we have either surgery or TIVA, right?
Yes.
Which one is better? Which one less mortality? Which one is
less mortality?
our first choice?
TIVA. Less mortality.
Yes. Even the guidelines, they said now the first option should be the TIVA.
Yes.
Okay. So now this is the only place where TIVA work better than surgery. There's some places where it's like rupture aneurysm also is one of them. Also, TIVA work better than surgery, and this is the second one. Whereas you have a grade 3 or 4, TIVA work better than surgery, and this is being approved by, of course, statistics and papers. So you just do a TIVA, okay?
Yes.
When you do a TIVA, you do it right away or you wait?
Right.
For sometimes.
In type 4 injury, we should do it right away.
No.
Even if there is another
emergency.
injury. Yes, emergency.
1 and 2 is a conservative. So our problem is number 3, right? So number 3, should we do it right away or it's better to wait?
No, it depends on the general condition of the patient first. And if there is concomitant severe injuries need to be managed early as a severe splenic injury or hemoperineum and other injuries. So it's considered not a top emergency to go forward to R, in relation to other severe injuries. If the patient will need aggressive resuscitation to, in some cases of head injuries, so in this case we can go for R to avoid rupture. That's what I know.
Okay. Yes and no. So number 3, it's going to be a TVAR. The question, should we do it right away? Like this patient, should we do it right away or wait for 24 hours? Okay. All the studies showed that the mortality is less if we wait 24 hours. Don't do it in the first 24 hours. Okay. But sometimes, except in some situation where you have to do it in 24 hours. Like if you have an extensive mediastinal hematoma, you have a huge left hemothorax, you know, then you have to do it as soon as possible. Or pseudocoarctation, like any sign of big hematoma, hemothorax, then don't wait. But if you just see it there without any other secondary sign, no hemothorax, no extensive mediastinal hematoma, it's just pseudoaneurysm, then don't get panic. You don't have to do it overnight. Better to wait 24 hours, give some time to resuscitate the patients, you know, and fix other injury, and then you go and do a TVAR. And this is the way some people, they start do it medically, because they notice that they are waiting. Sometimes they wait 2-3 days and nothing happened. They say, okay, let's continue conservative management, you know. But I remember one time I was talking to Dr. Jamal Hubballah from Lebanon, and it's the same. He has a patient, a young guy with a stage 3, grade 3 injury. And he was waiting on him because he had other injury. And unfortunately, he ruptured middle of the night and he died. So it's always a risk, you know. But let's talk about paper. Paper always, they said that if you can wait 24 hours, it's better not to do it first 24 hours. But if you have any sign of emergency, or like, again, like hemothorax, extensive mediastinal hematoma, pseudocoarctation, then you should do it as soon as possible. The other problem is that when you have a concomitant central venous system injury, then they like to keep the blood pressure high to get, you know, blood flow to the brain. And you don't want to give high blood pressure with a patient with a coarctation of the aorta, with a transection. This is other indication, is that if you have a concomitant central nervous system injury, then you do a TVAR as soon as possible, so they can feel free to give a high blood antihypertensive therapy or beta blockers, because they don't want to give antihypertensive medication or beta blocker with patient with a concomitant central venous system. You understand what I'm saying?
Yes.
So patient has a head trauma, because if this patient is going to wait 24 hours, you have to control his blood pressure, you have to put him on beta blocker. You can't keep pressure like 150, 160, correct?
Yes.
So you need to lower his blood pressure, because otherwise he may rupture. So you have to put him on beta blocker. But then you call a neurosurgeon, they come, neurologist, and patient has central venous, like, you know, injury. He said, oh, I need the good pressure for the brain, because, you know, is intracranial pressure related to the systolic pressure. When we do like carotid, we raise the blood pressure, right? Because you need to keep blood flow to the brain, right? So usually the neurology like to keep the pressure high for the brain, and then you have a problem. Then in this situation, of course, brain is more important. Then I'll go right away about a TVAR, so they can feel free to give blood pressure medications, okay?
Yes.
To keep the pressure high side.
Yes. In our oral exam,
so you have to take case by case. Afwan?
In our oral exam that in September, the trauma case was pseudoaneurysm, and the same scenario that you mentioned. That the patient has a severe head injury, and he has severe head injury and the neurosurgery and ICU, requiring aggressive resuscitation to prevent hypotension. And they asked, what should we do now in this case? So the answer was take the patient to TVAR, as long we will aggressive resuscitation for the patient.
Right. But if you don't have this sign, the paper showed that if you do it within 24 hours, it's not good. It's better to wait. You see? So if you don't have any of this injury, patient is stable, no extensive hematoma, no hemothorax, better to wait 24 hours, get the patient better, resuscitate him a little bit, and then do it after 24 hours. Okay?
Sure.
Any question about injuries? Okay. For the exam, if you want to go with the guideline, if you have a peri-aortic hematoma, they go with the size. You have to mark the size more than 15 millimeters. She should undergo an emergency repair. So if you see grade 3 with a hematoma, you measure the hematoma. If it's more than 15 millimeters, then it's need for emergency repair. I don't know where this number came, but maybe you need to remember this number for the exam. Okay? Because
And
you just
no
say large
oversizing.
hematoma. Sorry?
And no oversize
Right.
more than 10%.
In the thoracic, in the transaction, we don't oversize. That's correct, or at maximum 10%. But the most important, you don't want to undersize because patient could be hypotensive, when they did a CT scan. So you have to be careful also when you measure it. Was the patient hypotensive when they did a CAT scan? Maybe this scan, if you have an IVUS, use an IVUS. But usually I will put at least 10%. I will not put 0%. And I'm afraid that the CAT scan during patient was under resuscitate, because if you put a small one, can jump down to the aorta and you get a major problem. So also you have to be afraid of oversizing. No ballooning, guys, no ballooning. Most important, when you put thoracic transection, don't balloon. It's very important. Second thing, let me talk about this one. I just remember. When you do aortic transection, the most important part is to use super stiff wire, Landerquist or backup wire. You cannot use like stiff glide wire or something like that, because the aorta already traumatized. If you don't have a super stiff wire, when you push up, you're going to push against the aorta, you can rupture. And I saw one case, they're not using the right wire and they were trying to advance the device and the wire keep buckling up because it's not very stiff, and patient rupture right away and die. So in traumatic, it's very, very important. I will not even do the case without backup wire or Landerquist wire. You have to be super, super stiff wires. Okay, this is very important. Second thing, no ballooning, but very important. We don't balloon. When you finish, just put it there and get out. We use a short one. We don't have to put a long one. You just put 10 centimeters. Covering subclavian artery is not a big deal. You just cover it. Don't worry about it. It's not the time to do subclavian bypass. And nothing usually happens with this kind of patients, So you can cover subclavian nicely if you want to. If you want to get a landing zone. In the aortic transection, 10 millimeter is enough. You don't need 2 centimeters like we do in aneurysm, because the whole idea from transection is to land the aorta, just to put a graft inside, so give some time for remodeling. It's not looking for endoleak or something like that. So in aortic transection, 10 millimeter is enough as a neck. Even some people, they went to 5 millimeters, but most people agree at least on 10 millimeters. The last thing I want to say, if you finish TVAR after aortic transection, do an angiogram, and you see like still leaking around like that one endoleak, don't worry about it. Don't go and ballooning or don't put another stent inside, because the whole idea is just want to stabilize the aorta. It's not like you want, so don't worry about it. So if you do angiogram, you see like blushing around the aorta, don't worry about it. Leave it alone. Unless if you have a free rupture, is different, because free rupture, then you have to be sure there's no extravasation. But if just a pseudoaneurysm grade 3, just put a TIVA, do an angiogram. It's a good position. Even see some flush around it, it's okay. Don't worry about it. And you're done with that. Any questions about blunt trauma? It's a very important subject, and I'm sure guys get a lot of questions in the exam. Blunt thoracic trauma. Mortality usually with the traumatic aortic injury is about 80%. It's very high. Even people reach the hospital, 50% will die. So it's high mortality. So you have to be very careful and very aggressive with this kind of patients, All right. No more question? All right, let's keep going. We didn't answer it, right? We didn't answer this question. Sorry. Talk and
Yes, we
answer
didn't
the question. That's good.
So I think we discussed and answered. Anyway, we'll see.
What's the answer? Let's go one by one, see why it's wrong.
Yes, no intervention is necessary. Recommended for up imaging 1 week. Strong. Repair at a dissection of at a Discretion of the trauma team.
Discretion. It's not their
No,
job. No.
no. Stabilization of the
Okay.
concomitant injuries, anti-impulse control, semi-elective repair, no. Immediate repair, this is the right answer. Semi-elective open repair with the blunt aortic injury, no. The answer is D, immediate repair.
Okay. Why immediate repair? Let me see. What kind of injury is this one? Let's see. 24's motorcycle, he arrived hemodynamically stable. No neurological exam. CT showed aortic injury along with left pneumothorax, mohemothorax. Has pink laceration, multiple rib fracture, the most appropriate diagnosis, most appropriate treatment. So we need to do immediate repair. We don't have a hematoma, we don't have hemothorax, you know. He has a pink laceration, you have to take care of it. He's stable. Neuro is exam, so they don't have to worry about his brain. This is what I said, normal neurological exam, right? So I think this patient, no, I will not rush to take him to the surgery, you know. And you see the injury is not too bad. You can see it here. Like, you know.
But
like,
this is not extravasation of contrast? Damage.
No, no. This is no. It's not. This is the way they see the aneurysm. You see, this is a tear here and the aneurysm. No extravasation. No, you don't see hematoma here. You see any hematoma? There's no hematoma around it. See, so I don't see any sign that you have to be rushed with this patient. He has other problem. He has bleeding. He may die from spleen bleeding, laceration. So I will not jump to him. Let them go do the spleen, open the belly, put a chest tube for hemothorax. Hemothorax is different, but this is pneumothorax. You see. So as a hemothorax, I may be worried. Yes, I agree. But because I said pneumothorax and normal brain, just spleen laceration, multiple fracture, then I will let them do the spleen, fix it with chest tube, and maybe take him after 24 hours.
Yes.
So I think I will stabilize of concomitant injury, as we said. Anti-impulse control, we can give antihypertensive because if you want to control blood pressure, and then semi-electives, because grade 3.
Yes.
Okay. Everyone agree? Anybody has a question or is clear? All right. Looks okay. All right. Let's go back to who? Who was us? Any volunteer guys? Maitham, you want to go back again?
Sorry, Dr. Samer, just give me like 5 minutes. I'm driving now.
No problem. Let's go back to Ahmed.
Okay.
Where's Bara and Yahya? I don't see them.
I think they are in the emergency rupture AAA.
Oh, really? Have a rupture AAA?
Yeah.
Oh, is a new patient or our patient?
A new patient to ER.
Wow. Oh, okay. That's why they are busy. Okay.
27.
And door open.
I'm not sure. I left them were stabilizing the patient.
Oh, okay. All right. What is
A 27-year-old woman involved in a high-speed motor vehicle crash suffered a traumatic brain injury with intraparenchymal hemorrhage and underwent thoracic endovascular aortic repair (TEVAR) for a grade 3 blunt aortic injury. The following morning, the left subclavian artery was partially covered. 6 months later, he presents with bilateral lower extremity weakness, numbness, and pain. Based on the CT angiography findings in the figure, the most appropriate management is the stent is thrombosed.
Yeah, it's almost thrombosed. You just have a small, very small lumen, right?
Yeah.
And he came with extremity weakness, numbness, and pain. What is
spinal cord ischemia, maybe?
Yeah, right. So, guys, always spinal cord ischemia. I mean, I see that some people, they come with lower extremity weakness. They call the orthopedic or spine surgeon to do MRI, and they said patient is fine, and nobody have to check the pulse and femoral pulse. So aortic occlusion can cause an ischemic, spine. So always back in your mind. I see a couple of cases like that being missed because they came with neurological symptoms. They call neurology, never call it vascular, and nobody has a chance to check the pulse in the femoral artery. So again, you have to be very careful. This patient almost has an occlusion. He has very, very tight stenosis here. You can see it. So he has a low perfusion to the spine, and the reason why he's getting like this weakness, and numbness and pain.
This is short TEVAR stent, صح؟ كأنه 10
It's always we do a
centimeters.
short. Always we do a short. As I said, in the TVAR, in the trauma, we just put 10 centimeter, the shortest one, because your trauma is very short, 2, 3, 4 centimeter maximum. So 10 is enough. You don't have to put a long one. Okay. All right. Well, let's see what happened with this patient. So what you need to do with this patient?
Immediate systemic anticoagulation and CT angiography surveillance. Not for surveillance. This needs an intervention, but he needs
Right. Patient is
anticoagulation.
symptomatic. Yeah.
Yeah.
Okay.
B, magnetic resonance imaging and neurology consultation. No, the cause is clear a bit.
Right. If the CT scan is negative, then I will do that. I'll get MRI and neuro consultation, but you can see the problem there. So I will not jump to this one. Okay.
Cerebrospinal fluid drainage, CSF drain, spinal drain, and intensive care admission and serial examination. No, the cause here is not because of inflow of spinal hypertension. I think.
Right. I will not do a CSF drainage as a first option here. And CR examination, you have to treat this patient. You can't just do CR examination. So I think this is wrong.
And then
Okay.
emergent angioplasty and distal extension of thoracic, and they would be very reasonable.
Okay.
E, angiography of the left subclavian artery and revascularization, assuming it was partially covered. No, the priority is for D. I would choose D.
Yeah, because cruciate subclavian can give you this paraplegia and all the thing, because as I said, short stent. If he has like a stent from subclavian all the way to the celiac, then I understand that maybe subclavian occlusion causing this ischemia, because we know the spine get major blood flow from the, subclavian artery. So, but this one very short stent, so it cannot be because of the intercostal, So it's not the. So I think the main issue here is that you have a problem in the stent, you have to fix it, Emergent angioplasty and extended this extension, I think is the best way. But I never saw something like that, really. I mean, I saw picture like remember one patient came with a continuous embolization. I see embolization from inside the stent. Sometimes they form a clot and they get this embolization. And this patient, we did embolectomy on him like 3 or 4 times. I don't know if Ahmed remember him. He's a young guy. We keep doing embolectomy. He go back for 5-6 months, come back with another emboli. Then we did a CT scan. We found he has a clot inside the stent. Exactly the same picture. Yeah, he had a TVAR before like 10 years ago because of the car accident. So we went there and we put another cover stent inside, and since that time he's doing fine. So, but I'll not do angioplasty because I may be afraid of embolization. I'll put stent first and then I'll embolize. So at least the clot will be squeezed outside. But if you do balloon angioplasty first, there's a risk of embolization. So you have to be.
Let's keep going. All right. Who's going to take next? Sorry, Samer, only you and Ahmed here today.
لو أسامة left فصل عنده على ما أعتقد.
Well, let's get volunteer from anybody. Volunteer, guys, from the audience. No. All right.
Yeah,
Well,
Dr. Samer.
yes, go ahead, please. Ahmed.
Assalamu alaikum.
Salam.
72 years old man with history of chronic obstructive pulmonary disease, hypertensive, smoker, presenting with 6.7 cm type 4 thoracoabdominal aneurysm. He is seen by pulmonologist who deems high risk for open surgery. Which of the following is true regarding endovascular repair of thoracoabdominal aortic aneurysm?
Okay, so we have a patient, he's 72, he has 6.7, so we have indication to do it. Type 4 thoracoabdominal aortic aneurysms. The problem, he's not candidate for open because he has severe COPD. Okay?
Yes.
So he's tell us that if you do endovascular, which is BVAR or FEVAR, is what they mean, or SHEVAR, but SHEVAR is thoracoabdominal type 4 is too much. Mostly we talk about BVAR and
Prevention.
and yeah, BVAR and FEVAR.
Yeah.
So let's go with the question approximately. Go ahead.
Approximately 15% of patients will require secondary intervention on their renal arteries.
So after
Depending.
fever, yeah, after fever, the most common problem you can get after fever or fever is the renal artery occlusion, stent occlusion, you know.
Yeah.
And you know why that? Because you see renal artery keep moving with the inspiration and expiration, with the during respiration, right? The reason why we don't want to do an angiogram, you ask the patient to hold the breath, right? Or ask the anesthesiologist to hold the ventilators. Because patient keep breathing, you see the renal artery go up and down, you know. Where celiac and SMA is more fixed. But the renal arteries, they move a lot. The reason why the most of these patients, they end with stent fractures, you know, with the time, after a long, long time. So most really issue, it comes after fever and fever from the stent in the renal. Very rare to get a problem from a stent from celiac or SMA. So the risk of reintervention or the chance of reintervention in the renal is a bit high, but not 15%. I think it's too much. Can you guess a number? Just guess a number for intervention. It's about 5 to 6% usually for renal artery.
But equal fever or before,
yeah,
this is
it
the question.
doesn't make a major difference. Right? We get into that I think later on. But yes, no big difference between fever and fever.
But little bit less, yeah.
But less than
15%. Yeah, okay.
Usually it's 5-6%. Celiac SMA maybe 1%. SMA maybe 3%, much less. But the renal is the most one. So always if you want to give you a number, the worst renal, but 15 is too high. I think it's like maybe 4 or 5% is more reasonable. All right, let's go to the next one.
Patients suffering from spinal cord ischemia are most frequently treated with perioperative steroids.
Okay, so what they're trying to tell you, or there was a question that if you do a fever or fever, and next day you come and see the patient has a paraplegia, what do you do first things?
I think patient need the drainage urgent.
Yeah, right. So you need a drainage, right? So patients from spinal ischemia after EVAR or BVAR, it's not, they don't give cortisone. I mean, you may give cortisone, but it's not the treatment. The treatment is to go and drain, right? As soon as possible. It's like an emergency, guys. It's very important. I always tell the nurses, if the middle of the night you get any numbness or weakness in lower extremity, they have to cause an emergency. You have to drain as an emergency. You cannot wait next day. Don't wait for MRI because it takes a long time by the time. Because we did a study, we noticed that the sooner you drain the spinal cord, the quicker the spinal cord will recover. The longer you wait, the higher chance of it taking longer to recover. And if you pass a certain time, it becomes irreversible ischemia. So please, guys, treat spinal cord ischemia after EVAR, TVAR, whatever endovascular procedures as an emergency. And put that in chart so the nurse know, because they don't know. Maybe say 2 a.m. morning has happened. Okay, say, okay, we'll let the doctor know next day in the morning. Be too late, okay? If you already have spinal cord ischemia, what do you do?
For this patient?
In general, like patient, you finish your BVAR or FEVAR and you have a spinal cord ischemia, you already have a spinal drainage, and the nurse call you at 2 a.m. morning to say, oh, he has a paraplegia now. He was fine after procedure. Now he has a paraplegia. So what do you do?
I should stabilize my patient first with his blood pressure should be not to be low. I need to start steroid infusion and going for drainage. This is the gold standard.
He already has a drain.
Yeah. So all are conservative, hydration for the patient, control blood pressure, steroids.
Before that, what you have to do, first thing, be sure that the drain is working, because maybe it's kink.
Right. Yes.
So the first thing I tell them is that your spinal cord is working, because maybe it's not working. Maybe it's kink. So you see the tube is very small, very easy to be kink, especially patient lying in his back. So it's very easy to be kink. So if he has a spinal cord, first thing, be sure it's functioning. If it's functioning, then you go with the other measurement, you talk about it. If it doesn't have a spinal cord, the first thing you put a spinal cord, you put a drainage, if it doesn't have a drain, okay? Then you focus. As a measurement, you have three things or four things. First, you need the blood pressure to be high, at least 150, 160. You need hemoglobin to be at least above 9. Some people even say above 10. Third thing, you need saturation to be more than 95%. Okay? So the first thing, with a drain, how much is hemoglobin? 8, 7, 8 is not acceptable. Give a blood. Okay? Sat 90, 92 is not acceptable. You need saturation more than 95 and above. And well hydration. But this is the three things: hemoglobin and blood pressure has to be corrected. And again, the most important, to drain the spinal cord. Okay. When you drain the spinal cord, you want to keep the pressure less than 10. This is if you patient after surgery, you want to keep the, if you put a drain, tell the nurse to keep the pressure less than 10. But the most important, you write that, tell them you need to zero the spinal cord or the drain to the level of the spine, not the heart, because the nurse in the ICU, they always level the line to the heart level. But this one, it has to be leveled to the spine. So you have to tell them, they don't know that, okay? Because 0 to 50 has a spine level, not the heart. So you have to know that, because make a difference. Second thing is that you need the pressure less than 10. But I always write to them that if patient get any time paraplegia or neurological symptoms, open it to gravity, just open it completely and call me. Don't call me and then wait until I come, because it may take half an hour. So the moment they get neurological symptoms, open it completely and leave it drain as much as you can until you come and you evaluate the situation. Okay? Last thing, don't drain more than 20 cc per hour, because you may get herniation, you know, brain herniation. So again, tell them don't drain more than 20 cc per hour. And if any time you see blood in the fluid, spinal fluid, try to turn it off, because that you mean a hemorrhage. This is very bad. Okay. So all these notes, I think it's better if you can, if you do like this kind of procedure at your hospital, maybe make protocol, write it down so they know that. So you don't forget any of these ones when you give it to the nurse for, because this is the worst complication could happen after a procedure, which is spinal cord ischemia. And the good thing is majority of the time is reversible if you really treat it correct, you know. Any question about spinal cord ischemia?
But for this patient, Dr. Samer, sorry, يعني, for يعني this choice B, it means that they did the intervention without drain. So it's logic. Or...
So surgery with a drain, which is B, then say that the patients suffering from spinal cord ischemia are most frequently treated with a perioperative steroid. No, most treated with a drain.
Yeah, that's what I mean. Okay.
Right?
Yeah, I agree.
Don't give steroid. Steroid is very, very good to give the edema, but it doesn't work much really. The most important to drain it, you know.
Okay. So next, there is no difference.
You know why we drain them? How does it work? Why the drain work if you have an ischemia? Because the spine perfusion is equal to the blood pressure minus the fluid pressure, the perispinal fluid pressure. So spinal cord perfusion equal to systolic pressure minus the spinal cord pressure, or the fluid around the spine. So if you want to increase the spinal cord flow, either you increase blood pressure or you decrease the pressure in the perispine space by doing a drain. This is a concept from behind using a drain. Okay.
Okay.
All right, let's go to C.
There is no difference in branch vessel outcome between juxtarenal and thoracoabdominal aneurysm treated with fenestrated endovascular aortic aneurysm repair versus branched endovascular aneurysm repair.
Yeah, I was telling you, it's the difference between the patency rate between BVAR and FEVAR. There's nothing, it's no difference.
Right.
Yeah, so I think must be the right question. So there's no difference between BVAR and FEVAR. It depends on the anatomy. How you choose to do BVAR or FEVAR, it not depend because the branch patency is better. Both have same branch, you know, patency rate. But if you do FEVAR or BVAR, depend on the anatomy, you know, how you decide to go. If the aorta is narrow or you have a space or what, it's a lot of things. Do you have an over the shelf for, you know, BVAR, where FEVAR you have to be custom made. So it's a lot of things you have to look for it. but not the branch patency. It's the same. Okay.
Yeah.
All right. Let's continue that.
So next, there is higher risk of stroke with the use of upper extremity access. I don't think it's not related.
Yeah, you see what they mean, that now most people, if you do a beaver and fever, they try to do from the groin because they're afraid that because you do a beaver and fever, usually you go from the arm because it's easier to go and cannulate the branches from above. But some people, they are afraid that it's increase your stroke. So some people now start doing everything from down, from the groin. But really, none of them showed that if you go from the arm, increase your chance of stroke. The reason why, because most of the time you use the left arm. The left arm is away from the arch, from the carotid. Unless if you have a disease, shaggy aorta, it's different. But in general, going from the arm will not increase chance of your stroke, okay? If you have a normal arch. All right.
Okay.
Last one.
So last 30-day mortality for fever exceed 10%.
Yeah, I think it's too high.
I'm not sure really, but I don't think that's high like this.
Yeah, it's not high like that. This is, that's why I do beaver and fever. So it's about like maybe 4 or 5%. I will not go more than that, So mortality. So 10% is too high. Again, I mean, it's not a good questions, I don't know what the message you're getting from these questions, but we learned a couple of the things. We learned how to deal with the spinal cord ischemia. We learned that, going upper extremity, don't be afraid going upper extremity. Unless if you go from the right, then you may increase your chance of stroke. But if you go from the left, I think you'll be fine. Mortality is not too bad. All right, any questions? I think we'll stop at this level, especially most of my fellows not here today. Hopefully we continue next week. Any questions?
Thank you.
Thank
Okay,
you,
guys.
Dr. Samer.
See you next week. Take care.
See you.
Bye-bye.